As Janice mentioned, I am an oncologist, palliative medicine physician, and healthcare disparities researcher. And so when I think of healthcare disparities in my own research, I focus more on racial and ethnic minorities, so Blacks and Latinos or Hispanics, however you prefer to address them. But that doesn't stop there. It's age, it's sexual orientation. It really does span the gamut. And I think the thing about disparities is that it travels throughout the trajectory of cancer care. So it's prevention, diagnosis, treatment for those who are able to move on to survivorship, and then for those who can't and go more into end of life. And along every route in that pathway, there are disparities, so that we know racial and ethnic minority patients with cancer have poorer outcomes overall across that spectrum, no matter where they are. We tend to think of disparities in the conceptual framework of access to care, receipt of care, and quality of care. When you think of access to care, Mount Sinai is an NCI cancer designated center. About 10 to 15% of all cancer patients get their care there, and NCI designated centers are considered, the elite places for patients to receive cancer care. But yet only about 1% of racial and ethnic minority patients receive their care at NCI designated centers. And so that's a disparity, because we know patients who get access to care at NCI centers have improved outcomes because they have access to clinical trials. So although there's a small proportion of cancer patients overall who use and are enrolled in clinical trials, that proportion is even smaller among racial and ethnic minorities. And so when I look at these studies and I'm looking at real world applicability to my minority patients, I assume that what is found in majority white populations in these trials also apply to the non-white patients, but I don't necessarily know if that's true, because there are biological differences in cancer, and that can go across race and ethnicity. And so there are a multitude of gaps that exist there. When we think about access for supportive management, for Symptom, for example, I will tell you that minority patients have their pain assessed less. They receive prescriptions for opioids, for pain medications, less, and they're less likely to find those pain medications in the pharmacies that serve them. So someone did a study here now, almost 15 years ago, that has been reproduced in other urban centers like Detroit even more recently. And here they surveyed pharmacies that served East and Spanish Harlem versus the Upper East Side. And the pharmacies on the Upper East Side, by far and away, by about 30% more, had opioids in stock compared to those pharmacies in East Harlem. And so if I give a patient a prescription for pain medication because they have pain, and I send them out into the world and they come back into the emergency room, and I think, I gave you a prescription for pain, why didn't you take it? But if they didn't get it, then that's a problem, right? And so these are some of the challenges and the issues that we face. When we talk about receipt of care, I think something that is important that we're starting to talk about more, but we haven't really talked about a lot, is implicit bias or unconscious bias. So, I think as clinicians, we all are well-intentioned and well-meaning, and for the most part, the rates of explicit bias or stereotyping is very low. But we know that physicians have implicit bias, and we make these split-second decisions about people based on our own upbringing, on the environment, and sort of the more challenged we are in our day-to-day practice of returning patient phone calls, seeing a patient with cancer with a myriad of problems in 20 minutes, writing my research paper, coming to this meeting, all of the competing interests that I have, that sort of makes that bias worse. It makes those split decisions worse. The other thing I wanted to mention that was mentioned before by the people before me is the social determinants of health. So when I think of probably one of the biggest shortcomings we have in healthcare, it is that we do not address the social determinants of health. We do not have anything set up within our healthcare system that does that in a meaningful way. When I have a patient who has cancer who can't work, who has family that has to work to help provide, to pay the rent, to keep the electricity on, how are they going to get food? How are they going to get the care that they need if they're bedbound or ill from the chemotherapy that I'm giving them? And we know that this burden disproportionately falls to racial and ethnic minorities. And so that is certainly another concern that we have. I will add communication is a big issue, language barriers, for example. As a clinician, I often see if a patient speaks a different language that the clinician will yell louder in English. And the person's not deaf, they just don't understand English. And so, while I think most centers have interpreters available, that's not something that's always reliable, because I can tell you, as someone who can speak Spanish, I've seen interpreters say things differently than from what the clinician was actually trying to relate. And so there's a disconnect in that. Often these interpreters are over the phone. Some interpreters don't feel comfortable talking about challenging issues like death and dying, like incurability of disease, and so they sort of sugarcoat it and gloss over it because that's a cultural thing. And then in terms of clinical trials, we talked a bit about the fact that minority patients access clinical trials less, that there are sometimes some cultural beliefs around feeling as if they're a guinea pig or some sort of test subject, which is rooted in real life feelings, right? The Tuskegee experiments, et cetera, and ways in which we can think about how to move past that to really get patients, racial and ethnic minority patients, the care that is the best kind of care. And then I think one of the last things that I want to mention as I was listening to the prior presenters is that, we talk a lot in medicine about things that we found in populations that may work, but then they never get implemented. And so thinking about, sort of technological solutions for how we can implement the things that we know works and get them to broader audiences, I think is also helpful, because that's also another shortcoming that we have when we think about disparities. So that's it.